At 62 years old, I was waking up 4 to 6 times per night to urinate, experiencing incomplete bladder emptying, and suffering from chronic pelvic discomfort that was destroying my cognitive performance and research productivity. After implementing a precise molecular intervention protocol I developed through extensive literature review and personal experimentation, I reduced my nocturia episodes by 87%, achieved complete bladder emptying in 94% of voidings, and restored 7.2 hours of uninterrupted sleep per night within 90 days. My name is Dr. Walter Miles, and I serve as a professor of genetics and metabolic biology at Stanford University School of Medicine. My research focuses on cellular aging mechanisms and metabolic dysfunction in age-related pathologies. When I began experiencing severe lower urinary tract symptoms, I applied the same rigorous scientific methodology I use in my laboratory to develop a comprehensive intervention protocol targeting the root molecular mechanisms of age-related bladder dysfunction. I will present the 5 critical mechanisms I identified and the specific protocols I implemented to achieve these measured results. Each mechanism addresses fundamental cellular processes that deteriorate with aging, leading to the cascade of symptoms most men experience after age 60. Mechanism 1. Optimizing detrusor muscle contractility through calcium channel modulation. The primary mechanism underlying incomplete bladder emptying involves age-related dysfunction in detrusor muscle calcium handling. The detrusor muscle, which forms the bladder wall, requires coordinated calcium release from the sarcoplasmic reticulum to generate forceful, sustained contractions necessary for complete voiding. Research published in the Journal of Urology demonstrates that aging significantly impairs L-type calcium channel function and reduces calcium-sensing protein, calmodulin activity in bladder smooth muscle cells. This results in weak, fragmented contractions that leave residual urine, creating the sensation of incomplete emptying and increased urinary frequency. I implemented a targeted calcium optimization protocol focusing on 2 key interventions. First, I began supplementing with magnesium glycinate at 400 milliliters taken 2 hours before bedtime. Magnesium serves as a cofactor for over 300 enzymatic reactions and specifically enhances calcium channel sensitivity in smooth muscle tissue. The glycinate form provides superior bioavailability compared to oxide or citrate forms. Second, I incorporated a double voiding technique based on biomechanical optimization. Each morning and before bed, I would sit on the toilet, void normally, then remain seated for 60 seconds while performing gentle torso movements to redistribute any remaining urine pools within the bladder. After this pause, I would lean forward 15 degrees and attempt a second void. My objective measurements using post-void residual ultrasound showed a reduction from an average of 85 milliliters residual urine to 12 milliliters within 6 weeks of implementing this protocol. This represented an 86% improvement in bladder emptying efficiency. Mechanism 2. Restoring circadian antidiuretic hormone rhythms. Nocturia fundamentally results from disrupted circadian regulation of antidiuretic hormone ADH secretion. Normal physiology requires a 2-fold increase in ADH levels during nocturnal hours to concentrate urine and reduce overnight urine production. Age-related dysfunction in the suprachiasmatic nucleus leads to flattened ADH rhythms and excessive nighttime urine production. Research in the Journal of Clinical Endocrinology and Metabolism demonstrates that arginine vasopressin, ADH, circadian amplitude decreases by approximately 40% per decade after age 50. This results in polyuria during hours when urine production should be minimized. I developed a circadian optimization protocol targeting multiple pathways simultaneously. My morning routine begins with 20 minutes of direct sunlight exposure within 30 minutes of waking to synchronize circadian clock genes, including clock, BML1, and PER2. These transcription factors directly regulate ADH synthesis in hypothalamic neurons. Additionally, I implemented strict fluid periodization, consuming 75% of daily fluid intake before 3 p.m. My typical pattern involves 16 ounces upon waking, 12 ounces mid-morning, 16 ounces with lunch, and only 8 ounces total after 3 p.m. Complete fluid cessation occurs 3 hours before bedtime. To further enhance ADH sensitivity, I supplement with taurine at 2,000 milliliters daily. Research shows taurine enhances vasopressin receptor sensitivity and improves renal concentrating ability through modulation of aquaporin 2 water channels in collecting duct cells. Implementation of this protocol reduced my average nocturia episodes from 5.2 per night to 0.8 per night over 8 weeks, representing an 85% reduction in nighttime awakenings. Mechanism 3. Reducing prostatic inflammation through 5-alpha reductase modulation. Benign prostatic hyperplasia involves complex inflammatory cascades mediated by 5-alpha reductase conversion of testosterone to dihydrotestosterone, DHT. Elevated DHT levels activate androgen receptors in prostatic stromal cells, leading to excessive cell proliferation and inflammatory cytokine release, including IL-1V, TNF-A, and IL-6. Research published in Prostate demonstrates that chronic inflammation creates a positive feedback loop where inflammatory mediators further upregulate 5-alpha reductase activity, perpetuating prostatic enlargement and urethral compression. I implemented a multi-target anti-inflammatory protocol focusing on natural 5-alpha reductase inhibition. My daily regimen includes saw palmetto extract, Serenoa repens, standardized to 85% fatty acids at 320 milliliters daily. The active compounds, particularly beta-sitosterol and lauric acid, competitively inhibit both type I and type 2 5-alpha reductase enzymes. Additionally, I consume 30 grams of ground flaxseed daily, providing lignans that function as phytoestrogens. These compounds modulate inflammatory gene expression through nuclear factor kappa B, NF-κB pathway inhibition, reducing prostatic inflammation at the transcriptional level. My protocol also includes curcumin complexed with piperine at 1,000 milliliters daily. Curcumin directly inhibits cyclooxygenase 2, COX2, and lipoxygenase enzymes responsible for inflammatory prostaglandin synthesis in prostatic tissue. After 12 weeks of this protocol, my international prostate symptom score decreased from 19 moderate symptoms to 7 mild symptoms, and ultrasound measurements showed a 23% reduction in prostate volume from 52 ml to 40 ml. Reserme mechanism number 4, enhancing pelvic floor neuromuscular control. Age-related pelvic floor dysfunction involves both muscular weakness and impaired neural coordination. The pelvic floor muscles, including the levator ani complex and external urethral sphincter, require precise neuromuscular control for proper urinary function. Research shows significant deterioration in fast-twitch muscle fibers and reduced motor unit recruitment with aging. Studies in neurology and urodynamics demonstrate that pelvic floor muscle training can increase maximum urethral closure pressure by up to 40% through enhanced motor unit synchronization and increased type 2 muscle fiber cross-sectional area. I developed a progressive neuromuscular training protocol based on motor learning principles. My routine includes 3 distinct phases: isolation training, functional integration, and endurance conditioning. During isolation training, I perform 10 sets of 10-second maximum voluntary contractions with 10-second rest intervals, focusing on both urethral and anal sphincter coactivation. This targets type I slow twitch fibers responsible for postural support. Functional integration involves coordinating pelvic floor contractions with respiratory patterns and core muscle activation. I perform 5 sets of 20 quick contractions, 1 second hold, 1 second release, to enhance fast twitch fiber recruitment and improve reflexive sphincter responses. The endurance component consists of progressive holds starting at 10 seconds and advancing to 30-second contractions over 8 weeks. This protocol enhances mitochondrial density and oxidative capacity in pelvic floor muscles. Implementation of this training protocol increased my maximum urethral closure pressure from 68 centimeter mH2O to 94 mH2O as measured by urodynamic studies, representing a 38% improvement in sphincter function. Jacker mechanism 5. Optimizing sleep architecture through neurotransmitter balance. Quality sleep requires proper cycling through non-REM and REM phases, regulated by complex neurotransmitter interactions involving GABA, serotonin, and melatonin. Age-related decline in these systems contributes to frequent sleep disruptions and reduced sleep efficiency, creating a cycle where poor sleep further exacerbates urological symptoms through increased stress hormone production. Research in sleep medicine reviews demonstrates that fragmented sleep increases sympathetic nervous system activity, leading to decreased bladder compliance and increased detrusor overactivity through norepinephrine-mediated mechanisms. I implemented a comprehensive sleep optimization protocol targeting multiple neurotransmitter pathways. My evening routine begins 2 hours before bedtime with a warm bath containing 2 cups of magnesium sulfate, Epsom salts. This provides transdermal magnesium absorption and activates parasympathetic nervous system dominance through temperature-mediated vasodilation. 1 hour before bed, I consume a standardized tart cherry extract, providing 400 milliliters of anthocyanins, which naturally increase melatonin production through inhibition of indoleamine 2,3 dioxygenase, the enzyme that degrades tryptophan. This enhances endogenous melatonin synthesis without exogenous hormone supplementation. My sleep environment is optimized for thermal regulation at 65-68 degrees, complete darkness using blackout curtains, and white noise at 40 decibels. I utilize a continuous positive airway pressure device to maintain oxygen saturation above 95% throughout the night, preventing hypoxia-induced sleep fragmentation. The final component involves box breathing performed for 10 minutes before sleep onset. This technique involves 4-second inhalation, 4-second breath hold, 4-second exhalation, and 4-second pause. This pattern activates the parasympathetic nervous system through vagal stimulation and reduces cortisol production. Implementation of this protocol increased my sleep efficiency from 72% to 91% and reduced sleep onset latency from 28 minutes to 8 minutes as measured by polysomnography studies. Urology Complete Daily Protocol. My current daily regimen integrates all 5 mechanisms into a systematic approach. Morning, 6:08 a.m. 20 minutes direct sunlight exposure for circadian entrainment, double voiding technique with 60-second pause and repositioning. Breakfast, 1 cup steel-cut oats with 30 green ground flaxseed, 4 cup walnuts, 1 cup blueberries. Supplements, saw palmetto, 320 mg, curcumin, 1,000 mg with piperine, 10 minutes pelvic floor training, isolation phase. Fluid intake, 16 ounces filtered water. Midday, 12:02 bars p.m. Lunch, 6 Oswald salmon, 2 cups spinach salad with cherry tomatoes, 2 TBSP pumpkin seeds, 20-minute post-meal walk for lymphatic drainage. Fluid intake, 16 ounces, last major fluid consumption. Taurine, 2,000 mg supplement. Evening, 6:10 bars p.m. Light dinner, 4 Oz organic chicken breast, 1 small sweet potato, 1 cup steamed broccoli. Fluid cessation 3 hours before bedtime, 20 minutes leg elevation with ankle pumps, warm Epsom salt bath for 15 minutes, tart cherry extract 400 milliliters, magnesium glycinate 400 milliliters, 10 minutes box breathing, final double voiding before bed. Row, measured results after 90 days. My comprehensive outcome measurements demonstrate significant improvements across all parameters. Nocturia episodes, reduced from 5.2 plus 1.1 to 0.8 plus 0.3 per night, 85% reduction. Post-void residual volume, decreased from 85 ml plus 12 ml to 12 ml plus 4 ml, 86% reduction. Sleep efficiency, improved from 72% to 91% via polysomnography. International prostate symptom score, reduced from 19 to 7, 63% improvement. Maximum urethral closure pressure, increased from 68 centimeter H2O to 94 centimeter H2O, 38% improvement. Sleep onset latency, reduced from 28 minutes to 8 minutes, 71% improvement. Prostate volume, decreased from 52 ml to 40 ml, 23% reduction. These results represent clinically significant improvements that have restored my quality of life and cognitive performance to levels I experienced 15 years ago. Frequently asked questions. How long before I should expect initial improvements? Based on my experience in the literature, Most men begin noticing reduced nocturia episodes within 2 to 3 weeks of implementing the circadian optimization and fluid periodization protocols. However, maximum benefits require 8 to 12 weeks as cellular adaptations in muscle contractility and inflammatory reduction occur gradually. Are these supplements safe for long-term use? I've been using this protocol for over 2 years with regular monitoring through comprehensive metabolic panels and urinalysis. All supplements I recommend are well documented in peer-reviewed literature with excellent safety profiles when used at therapeutic doses. However, consultation with a qualified healthcare provider is essential before beginning any new supplement regimen. Can this protocol replace medical treatment for severe symptoms? My protocol addresses fundamental physiological mechanisms but should not replace appropriate medical evaluation and treatment. Men with severe symptoms, acute urinary retention, or signs of malignancy require immediate medical attention. I view this protocol as complementary to conventional medical care rather than replacement therapy. This comprehensive approach targets the root molecular mechanisms of age-related urological dysfunction rather than merely managing symptoms. Through consistent implementation of these evidence-based interventions, I have achieved sustained restoration of normal urinary function and sleep quality that continues to benefit my professional and personal life significantly. The key to success lies in understanding that these mechanisms work synergistically and require several weeks of consistent application to achieve optimal results. I encourage systematic implementation beginning with the most impactful interventions, circadian optimization and fluid periodization, followed by gradual incorporation of the remaining protocols.